Good afternoon, and welcome to this edition of HDSA and Me, a limited educational series that offers the HD community information on a variety of topics. Today we'll be offering a question and answer session on long-term care. You can send a question at any time during the session. Just click on the chat function in the toolbar, type your question, and hit send. Your question will be answered by one or more of our panelists. This presentation will be available in about a week on HDSA's YouTube channel. On October 7th, we'll welcome Dr. Kristen Rapp from our HDSA Center of Excellence at the University of Colorado and Dr. Michael Schrift from our HDSA Center of Excellence at the University of Washington to talk about psychiatric symptoms of HD. You can register for this session by going to hdsa.org/HDSA and me. And now a little about our speakers. Today we welcome a panel of experts on long-term care. Stacey Barton is a graduate of the Brown School of Social Work at Washington University. She's been the coordinator of the HDSA Center of Excellence at Washington University School of Medicine since 2006. In that capacity, she manages all aspects of the center, including clinical care, research, genetic testing, information and referral, health education, support groups, and counseling. In addition to her social work duties, she has served as a coordinator for Enroll HD, HDQ Life, Predict, and Cohort. Hope Heller is a licensed clinical social worker and a founding partner and therapist at the Heller Psychology Group, but worked with the Huntington's disease community for over 12 years, first as the HDSA chapter social worker, and then with the HDSA Center of Excellence at MedStar Georgetown University Hospital. Hope works with individuals and families on issues surrounding decisions about genetic testing, diagnosis, and progression of disease and illness. Hope strongly believes that everyone should have access to good health care, should be provided education on how to navigate our healthcare and long-term care systems, and that advanced directives are a gift we give to our loved ones. Gwen Johnson is a registered nurse at Good Samaritan Specialty Care Center in Robbinsdale, Minnesota, and has been the nurse manager of the Huntington's disease unit since 1996. Gwen assists residents and their families to navigate the challenges of HD and the issues surrounding long-term care placement. Gwen also supports and educates staff on caring for residents with HD. Gwen has previously served on the HDSA Minnesota chapter board and is certified in aromatherapy. Erica Wright received her Master of Social Work degree from The Ohio State University in 2009. Since that time, she has worked in the Columbus community in roles to support individuals with chronic health care conditions and disabilities. She's been the social worker at the Ohio State University Center of Excellence since 2015, providing support to patients and families, as well as providing guidance on navigating a number of topics, including community resources, disability benefits, caregiver support, long-term care planning, and more. Now, it's with great pleasure I turn the broadcast over to our panelists. Welcome.
Thank you.
Thank you.
Thank you.
So why don't we start off with a general question. Some of our audience may be new to long-term care and not really sure where to begin. So why don't we start with what you consider long-term care is?
Yeah. Long-term care to me is kind of the full spectrum of, care and support that someone's going to need over the course of their lifetime or progression of disease. That can be care that's going to be received in home, outside the home while still living at home, or eventual facility placement, whether that be assisted living or nursing facility. So a lot of different things that can be accessed to support people and families in providing care for their loved ones as needs change and grow.
Perfect. So I see a question in the chat. Sorry.
Go ahead.
So I see the question in the chat. What type of placement is available for HD patients? Anybody want to take that?
I think that this is Gwen. I think that it depends on what state you're in and what you have available. We do have some assisted livings. We have a few group homes here in Minnesota, and then we do have, a few facilities that take people. We do have the Huntington's unit since 1993. So I think depending on the states where, what you might have. And again, long-term care, are they just getting assisted living at home, some assistance too?
Yeah. I would add to that I mean, assuming we're talking about residential placement, so we're beyond the support in home for this particular question. Placement can kind of depend on what it is you need. So if someone is requiring rehabilitation following an illness or injury, you know, that would be one sort of placement that may not be intended to be permanent, but could become that way if rehab isn't successful or not fully successful. Some people need just a little bit of help at home, and Gwen mentioned a couple of unique options, such as adult care homes, and she said that's not available everywhere. And then assisted living can really mean quite a lot of different things depending on the facility offering that care. And so I would really recommend that when you go to a quote unquote assisted living, that you ask what's provided. I know some assisted livings in my area, I'm in Missouri, some of those are actually quite independent and really don't provide much more than housekeeping and meals. And then if you need, and then if you need additional services, those are sort of a la carte and charged separately. So if you need assistance with personal care or with your medications or that kind of thing, that's not part of the standard room rate there, but you can obtain it for an additional fee. And other places are more comprehensive, where it's sort of like a mini nursing home, but more private, perhaps, with your own room and, you know, that kind of thing. So you really want to ask, what does assisted living mean at your facility as you're touring these places? And what do I get for that fee that you're quoting me? Because you may find that there's some additional fees to get what you actually need. And then I think it could be helpful to address sort of the difference between skilled nursing and nursing home or long-term care or custodial care, because those can be different things. So I could keep talking, but I don't know if someone else wants to take skilled nursing versus long-term placements. Shall I keep going? Yeah, go ahead, Hope.
Gwen, jump in if I, so usually you hear like skilled nursing facility or subacute nursing facility as more of a rehab term. I think that gets used interchangeably with long-term care or custodial care. I personally think of it more as the biggest difference is just who's willing to pay for it. All of those things are typically done at the same type of nursing facility. The difference is if you are there for skilled nursing care or subacute rehab, those are meant to be short-term stays and are typically covered under insurances. When you reach a point where the idea is that you are just staying there for your care, that is considered that long-term or custodial care, and that is not covered under like Medicare or like a private commercial insurance. That would be covered private pay or Medicaid or long-term care insurance.
Right. And also something about skilled is like, I see the question there is like, when is it time for placement? You know, sometimes we'll get referrals for people who just don't need enough care. We know that they need supervision and all, that they're not best left to be at home and they do need some help prompting. But in order to come into a nursing home, you have to have some of that skilled care. And it is, those words rehab and skilled is a little different and short and stuff, but skilled care, when I'm talking, are they having some mobility issues? Are they having some issues with incontinence and stuff? That's what requires, that's what the state requires us to allow somebody to come into our place. We know it's progressive, but we have to have some amount of care that we're gonna be giving before it's okay to us to have them in here.
I was going to say that level of, I think there's different states have different like level of care forms that you have to agree to. Just also thinking about when it's time for long-term care, I think aside from the obvious like skilled level pieces that are needed, or those pieces that Gwen was talking about that are needed for like Medicaid and things like that, there's also the piece of personally, like when is it time for your loved one to go into long-term care? And I think that varies from person to person. I don't think there's a set timeline. And I think what I see is that every family is going to have their threshold. For some people, at the point in time in which their loved one can simply not be left alone because everybody works, that is the point in time in which they can't be at home anywhere. For others, they can figure out the care and can keep them at home up until they are no longer safe on stairs, or until they need X amount of hands-on care. And that's really going to vary. And I always tell families to really be honest with themselves about what they can manage and what they cannot manage. From, I think, the professional standpoint, what we would look for when I was at Georgetown was when somebody was coming in and it seemed like there was an increase in falls, or just more stress at home. I always look for the loved one and the family members to just seem a little bit more stressed out. And also to seem like when I see somebody whose patience seems a little bit thinner with their loved one, I don't think of that as anything wrong with them as a caregiver. I think it's usually a sign that the care at home is just too much. And what I think about is if somebody's in a facility, then it's fresh legs every 8 hours. And so I think at the point in which it just becomes too much for a family, but I think that time frame looks different for everybody.
I would say definitely that same thing, that it kind of is different for everyone depending on what your situation is and what kind of informal supports you have. If you have extended family or a church community or friends that are, chipping in and kind of helping give you some, informal respite and giving that caregiver breaks. If the primary caregiver needs to stay working or, caring for kids in the home or something, and we're not able to provide enough supervision or care in the home, and those needs are kind of outpacing what's available in the community, or when the caregiver's own health is being maybe jeopardized or impacted by the care that they're giving, they're not able to tend to their own medical appointments or follow up with the care that they need, or even just, to have that mental health break, and be able to, keep managing their day to day. That keeping the caregiver well is so important. And that's really oftentimes the key piece of somebody, being home and staying home, is being able to keep that balance for everybody, having their needs met.
Yeah, I would agree with all of my colleagues. And I would say as difficult as it is for us to give a clear answer on when it is time to go, I think we would all agree that we know when the worst time to go is, and that's during a crisis. And so often that's what people do. And I think that a lot of HD caregivers are used to doing a really hard job for a really long time. And sometimes it's really difficult to discern when I've crossed that threshold of when this is no longer a one-person job or when this is no longer a family job. And so waiting until it's a crisis is the worst thing that you can do, because then you're going to have fewer options. You're going to have, less reserve to go and tour and help the new staff get to know your loved one. I mean, all these things that you can think of why a crisis would be bad. And the crisis isn't necessarily the crisis in the person with HD. As Erica alluded to, we see a lot of caregivers who become quite ill as a result of that constant stress of caregiving. And so, trying to do this sooner when the person is doing better and there isn't a crisis is really your best option, I think.
And I would just remind caregivers and loved ones that if you start to feel like it's too much or it's impacting your health or something like that, it's not anything that you've done wrong. It's not that it's a really hard job, and nobody knows that more than a caregiver and the person that's doing it. And so it's okay to say, this is more than I can do. It's also a good discussion to continue to have with your doctors and with your team. I always encourage, if you have a doctor that your loved one trusts, to bring them in on that initial conversation if you're afraid to start that conversation. But I do think as the caregiver, it's really, you have to have that sort of hard conversation with yourself about, is this still working?
Yeah, and Hope, we did have that question in the chat of how do you start this conversation with your loved one?
I missed.
So no, that's okay. You actually, it was a perfect segue, and we'll get to some of the questions before that. But since you brought it up, I thought maybe we could go into that a little bit more. And so one thing I heard you say, Hope, was being ready yourself to know this is the right time before you start that conversation with your loved one, and trying to convince them that it's the right time is ideal. Any other tips?
I would say the earlier the better. You're just gathering information. It's like that little tool belt thing. You're finding out what is it? What would I need to make this happen? You know, primary care doctor. You need I would get somebody else on, like Hope said, get a doctor involved to start. So they're kind of sprinkling out, you know, say you might be needing a little bit more care. It's like I always talk about, like it's watering a seed. You kind of have it coming from all directions, and you know, someday this might happen. You know, and then because there's all the big financial piece too, which that's what these social workers and stuff do, you know, like to how is this going to look? So again, you're just gathering information. You're not committing to nothing. You're just helping, you know, like, okay, this is what I would have to do if that became that, you know, and then, yeah, does that sort of help there or something?
Yeah.
Get people on board. You don't have to make decisions. It's just information.
I think also to be really honest with your loved one about it. I always say, if this, you know, oftentimes when the decision gets made to move somebody to long-term care, it's not the decision of the person with Huntington's disease. And as much as we want to include them in as many decisions as possible for as long as possible, they often don't really have as much say once a caregiver says, I can't do this at, you know, this doesn't work anymore at home. This isn't safe at home anymore. And so I always say it's good to have the honest conversation. It's also important to not give the appearance that they can veto the decision if you know that decision is, and that's hard sometimes. That's really hard to say, I'm sorry that you don't like this, but this isn't your choice. But I also think you have to be honest, because I think to give somebody that, you know, that impression that they're allowed to say they don't want to go when you know that it has to happen, it's going to make it harder.
I think that's good
I think
advice.
starting early and having those conversations, so as much as your loved one can participate in the planning or decision making, depending on where you are at in stages of Huntington's disease, that you understand maybe some of their wishes or what they would want if this would need to happen, and kind of maybe starting to talk and have these conversations before, again, you're at that point where, you know, we're imminently thinking about placement, that you've had these discussions, you know, because for a number of reasons, if something happens to the loved one, or, you know, a move needs to happen if the normal care isn't available, that you have kind of this backup plan in place as far as, you know, maybe 2 facilities that you've seen that you're interested in, or that you toured with your loved one, if they're agreeable to looking and you know that they would be interested in, that you can call on when that time comes, and see what's available then. But I think definitely including your loved one as much as possible, and you know, just being honest, and as much as, you know, they're allowing for that in the moment of your conversation.
Yeah. And there's another really practical reason to have these discussions early. And I like the watering the seed analogy. I think I might steal that one. I think there's another really practical thing that goes along with that, which is figuring out the financial end of it. And there are certain aspects of this that can absolutely be done in a crisis. You know, there are plenty of people who go to a nursing home and they figure out how to pay for it that day. But obviously that's not ideal. And there are certain circumstances where that is absolutely what you don't want to do. And one example of that is if you're married, particularly, and you're likely to need Medicaid for your loved one, there are some legal planning tools that can be done in advance of that need for Medicaid to protect the healthy spouse as financially as much as possible. But typically, at least in my state, and I think this might be every state, that usually has to be done 5 years or more prior to going to the nursing home. And we never know when the nursing home is going to happen 5 years from now, right? That's a completely impossible crystal ball. But if you do it now and you have those discussions, you may actually protect yourself financially in a really significant way. So I would encourage that discussion.
Yeah, I think every state is different, obviously, with their Medicaid rules. And I think where I see the most, like the biggest problem that we run into is when the healthy spouse's retirement account is part of what's counted for Medicaid. And I believe that's true in my states. I think that's true in a lot of states, and that really runs into a bigger problem with with the Huntington's disease community, because the healthy spouse is usually still on the younger end. And so really planning ahead and working with, if you're able to, a good estate planning or elder care lawyer in the area. If that's something that you're able to save up for, to pay for, that really will save you, that can save significant funds. I think that there is a big lapse in what people can afford to pay for and what Medicaid and what the state says you have to pay for.
Yeah, so a couple of things. Deb Levecki is letting us know that HDSA has a relationship with Mass Mutual, who can assist HD families with planning. And you can contact Deb Levecki at HDSA, so D Levecki at hdsa.org. And also another resource that I would like to add to that is the National Academy of Elder Law Attorneys. You can find somebody who's a part of that in your state who will know these very state-specific rules. It's NAELA, the National Academy of Elder Law Attorneys. You know, yes, it costs money to consult with folks like that, but typically for a lot of people, that consultation will more than pay for itself.
Yeah.
So,
also, the further out you meet with those people, with those lawyers, the less expensive it is if they're not having to do a lot of fancy footwork to try to figure out how to.
Yes,
the legal planning tools are simpler.
Yeah, on the earlier side of things, to be ahead of them, definitely.
Yeah. So maybe we should talk about funding for these different levels of care. You guys want to go over that a little bit?
Sure.
All right. So maybe we can start with in-home care, since we're including this in our vision of long-term care. Does anyone want to address how in-home care is paid for?
I can start with that.
Okay.
So in-home care is typically private pay. I want to clarify. You may have a doctor put home PT in your order, home physical therapy or occupational therapy. And that may come with a home health aide that will come in for a few weeks, once a week, and do a shower for an hour or two. That is not what we're talking about with long-term care. That's meant to be a very finite amount of time and that's really the only type of in-home care that you're going to see covered by Medicare or commercial insurance. Medicaid, if you have Medicaid, depending on your state programs, there may be something called a Medicaid care waiver, and that may provide different levels of in-home help. I think every state is different. I know some states in my area, it's up to 8 hours, some it's up to 16 hours, but I also know that it's very it's not only state specific, but it's county specific. There are counties in my area where to get a Medicaid waiver, the wait list is so long you can't even add yourself to it. So you want to really think about the Medicaid waiver process and what that looks like ahead of time and understand what that is specifically for your county. There's long-term care insurance, depending on your policy, may cover in-home care and aid care, and then private pay. The other thing is family members, I find, are often the ones that provide the bulk of it. I think it's important that if you're the caregiver that's providing it, to know who your other family support members are and backups are. As Erica talked about before, caregivers have their own health issues and can get sick, and if there's an emergency, who's taking care of your loved one? Oftentimes I see that it's a combination of some private pay, some family. What are your other community members and what other supports? And I would also say for in-home care, it doesn't go from zero to, round the clock. Sometimes it starts with just needing somebody to check in on your loved one once or twice a day while you're at work, or come in and make sure they get up in the morning and medications are taken, or come in at meal times. And then it slowly builds from there. I tend to err on the side of start with a little bit more if you're not sure, and then scale back, as opposed to letting something happen. But again, those are pieces. Long-term care insurance, if you're going to use that, you want to read your policy pretty closely and know what the waiting period is in order to use it, as well as what the requirements are and how many activities of daily living, like showering, meals, getting dressed a person needs help with in order to qualify.
Yeah, and I would add that I think in most states, but maybe not all, so this is where it's really good to chat with your local HDSA social worker or someone similar. But in most states, I think those Medicaid waivers to get the in-home care still require that you have the same level of care need as nursing home. That they're kind of like nursing home diversion programs. So the idea is they'll pay for a few hours at home to help you stay out of the nursing home longer, but they're not going to pay for it if you're not ready for a nursing home.
Yes, that is true here as well.
Yeah, and to piggyback on the mention of the long-term care insurance, also just with your policy to see if it is a time-limited policy. For example, if it's only going to cover for 5 years of time, that's not something you would want to access when you're just very first, maybe starting with a little bit of help at home. You would want to save that to use when you're needing the more heavy-duty care or potentially facility placement to get the most value for your investment.
Yeah.
The other piece with that is, so with the waiting periods, you want to clarify if you have to show, if it's a 90-day waiting period, that the person has needed help for 90 days or that you are paying somebody for 90 days. Because I've seen that distinction and variation made in policies.
Mm-hmm. Yeah, and I would just add one other payer source that we don't want to forget to consider if you're eligible for it, is VA benefits do often provide some of this too. That's not a huge group of people, so we often forget to mention it. But if you are a veteran, please be sure to consider that possibility. So let's talk about paying for assisted living, sort of maybe the next step along that route of help. So
assisted living is not covered by Medicare for any reasons at all, and depending on your state, only some states do have a waiver that will cover assisted living care under Medicaid. So typically, otherwise, it is going to be a private pay situation unless you do have a long-term care insurance policy you could access to cover it, or you have another benefit through your state that you can access for that. Another thing that we haven't really talked yet as far as a potential financial resource to access to help pay for long-term care would be if you do have a life insurance policy that could be, does have an accelerated death benefit or something where you could get some of that cash value out now or use the funds now, which are then repaid upon the person's passing rather than there being a benefit to the family after the person's passing. So if you do have a life insurance policy, that would be another thing that you could look into the details of your policy and see if that might be a resource you could access to be able to help pay for this care, because it can be costly.
You also, just to add to that, it's a good point about the life insurance policy, because you also want to work if you are applying for Medicaid, you need to understand what the Medicaid rules are on the life insurance policy. Some life insurance policies have a cash value prior to death. And so that is typically considered an asset, whereas some do not. So again, you want to work specifically with your state's Medicaid rules and understanding that with your specific policy.
Yeah. And I think we probably addressed already paying for skilled nursing and long-term care a little bit, but Medicare and commercial insurance versus private pay versus, I think we probably addressed that one. We do have a few other questions in the chat. Someone asked, how can you find out what level of care is needed for your state?
So I always, as a great resource that every state should have, our area agencies on aging. I'm pretty sure they're all across nationwide. In Ohio, they're a really great resource, and they administer our Medicaid waiver programs here, and so are very familiar with the guidelines. So if you're able to look up your area agency on aging in your area, they should be able to give you some direction. For example, in Ohio, to meet that intermediate level of care, to be on a waiver program or in a nursing facility, you do need hands-on help with 2 activities of daily living. So things like bathing, dressing, toileting, mobility, hygiene, but it's very specific on that. So if someone's not quite needing hands-on care with those tasks, but they're needing, supervision, meal prep, housekeeping, all of those things, they don't quite meet that condition just yet. But obviously that is still a lot of help someone would need where they'll probably be needing care.
Gwen, maybe we can direct this one at you. When should I call a long-term care facility, or how far in advance should I tour a long-term care facility?
Again, all you're doing is, I don't think you could do it too soon, or just to find out, you're just gathering information. You don't have to make decisions. What are your options out there? Would you like to, is the nursing home down the street, a possibility? Do you have to look someplace else? So again, you're just gathering some information, maybe when you're starting to see more, maybe some falls or something at home, or some more care, help with cares that the family's not ready to, are able to provide as much, to start to be thinking about it. But I think the earlier, the better, because we know it is progressive at some point. It might be 10 years, but at least, you have options. Say this is a good place, or this place has private rooms, or this place has, and then you can include your loved one in a part of that conversation. It's like, because I'm with you guys about being, having them partially in, involved, not partially, but to be included in it. It's like, okay, but when you start to fall or some things like that, this will probably be the time that we're going to be looking at placement. And I also like to say people have choices, and I know that a lot of times they don't really have a choice, that they need to be someplace, but to tell somebody that this is it, too bad, so sad, and to not to have like any hope, that maybe, okay, let's try this. We're going to try this placement and see how it goes. And usually people, once they get settled in and into their new routine, they're pretty much adjusted. But to tell somebody that, hey, this is it, this is where you're going, you don't have any choice. It's just like, you're really shutting down and making it challenging none of us would like that neither. It's like, so by having them in that conversation, say, this is what you can get here. I know they don't always have a choice, but to have people a part of the decision and stuff, and understanding, that you're just not going there forever.
I think when it's one of the things you can do is, like, if they can give you maybe one thing that they feel like, I really want to be able to find this at a facility, or I really don't want to be at a facility, X facility, to give them some say in it, because you want them to have a choice, but it is a tricky balance.
Yes, yeah, very tricky. Yeah,
has to have placement. So, but Gwen's right. The more, we want to involve people in it, and
it's not a new topic. If you came up to me and said, hey, you need a wheelchair, Gwen, I don't think so. But, if you approach me over time, it's like, it's not that new of a subject. It's like, yeah, you're right. I am falling a lot, or, I do need more help, and I don't necessarily want my wife or my husband helping me with, or my kids for that matter and stuff. So it's, it's about being independent, and then you can be the caregiver and stuff, and letting us take on some of that stuff, again, part of their conversation.
Yeah. There's a related question to all of this, is if I toured facility and they have a bed, can I say, no, not now, and then they'll call me again, or do I have to start all over again with the facility?
It just might change. We have this list. I always heard about that. We have this big list, and sometimes it was a big list. And then people say, oh, we got a waiting list of a year or two and stuff. And I thought, okay, that list is really fluid, because we have a number of people who just want their name there just in case. They are so far away from any type of placement, but they just want us to know, so, the list is always changing. And I've talked to somebody and then not talked to them, for 4 or 5 years and stuff. So it's just, the list is changing. We can't always take whatever, or that person might be too early. We know that it'd be better if this person was probably placed in some care, or the person's just not ready, manageable right now, is not accepting of it, and, a little bit more challenging and stuff. So then maybe they're not appropriate to come into a long-term care facility just yet, but again, you're watering that seed. You're helping it kind of come along and stuff. And then so even if you came, I might have a bed today. I might not have a bed 2 weeks from now, but it is a progressive disease. I might have an opening. Sometimes we don't have an opening for a long time, COVID didn't hit us as hard, thank God, you know, as some of the facilities and stuff around the country. We were so fortunate. Sorry. So anyway, people weren't running to come into this nursing home and stuff, but, you know, we've got it pretty much handled right now, hopefully, you know, and trying to get back to some sort of normal. Respite, if we've got the openings, but I would say pretty much nursing homes across the country are challenged and stuff with, I mean, like our census is way low in our building where we use a 96 facility. We're probably in the low 80s sometimes, you know, so our unit has been full. And then we've had to take a few other diagnoses and stuff from it. But you know what? We'll love you up anyway. If you need care, that's what we're here for. You don't have to just, you know, we'll love you up and try to add some quality joy for the moments and stuff, you know, in your life.
Don't you want Gwen to be your caregiver when you need it? I do personally. So I just thought I would address respite. So respite can mean lots of things. It's basically a break for the caregiver, and what that can look like is different. The question that Gwen was referring to was one that was, do you suggest having the person spend a respite weekend at a facility? So you could hire somebody to come into your home to provide respite. Your loved one could go to adult daycare to provide you respite. But in this case, the question was about a respite weekend at a facility. I would say, I think that's fine, and it's worth doing, especially if you're a long-term caregiver.
And if you can manage it financially, however.
Yeah, I think those are lovely options. But to do that as a trial of trying out the facility may not actually be as helpful as you think, because weekends are different than days. They don't know you if you're only there a day or two. You know, if you're Medicaid in our state, will cover respite, but it's such a pain in the neck that most facilities don't do it because they still have to process it like a regular admission. And so, you know, basically all the legwork for a long-term admission. So I think respite weekends at a facility are a great idea for lots of reasons, but not necessarily if your only reason is to try it out.
Yeah, because then you got some option. It's like, no, you gave me the option. No.
Yeah, I think it can be a good tool for when someone is still at home and being cared for, and caregiver needs either just a break, has to travel out of town for work or a family event or something, can't take the person with them, to have that. And also that also can kind of be still planting that seed for the future that, you know, then they've had this experience somewhere, you've maybe familiar with a facility, and kind of get a little bit more comfortable with the idea for the future.
With the staff, the place and all. Yeah.
I just wanted to just add in, as we talk about like these conversations with loved ones, and it can be hard. And I think the assumption is always that our loved ones don't want to go and are going to be upset. But what I find is that the majority of people that I know, once they get to a facility and are settled, they're actually quite content. It's a good routine. You know, they get into a routine, they get to know their caregivers. They also no longer have to worry about their family members and if they're managing it, or if they're going to, you know, continue to be able to provide care. So I find that oftentimes we're very nervous about that transition, and the transition itself can be a challenge in some situations, but that that people actually do very well once they are there and are settled.
I would so say that is true, you know, it's not all roses and stuff like that, but it's that prior to, and then once the people get here, the trend, sometimes the families are the ones that are having, not sometimes, a lot of times the families are the ones that are having a harder time adjusting than the actual person and stuff. But then, like I say, once they get into a routine and
they also find that their family member or their caregiver, they actually have more quality, they see them less, but the time with them is more quality time because it's not spent providing hands-on care. It's spent just being with them.
So that there is a question about after the placement. So I've placed my loved one. What do I need to know about visiting, advocating, etc.? It's a great question in the time of COVID. So
I can say something. COVID's changed this whole world. You know, most people before COVID, we'd say, yes, come in unless you think they need a couple of days of adjustment and stuff, you know. You don't overwhelm them, you know, with their time in. But with COVID right now in long-term facilities, you know, it's usually 2 people in, you know. We're not in any lockdown, and we have not been, I think, only once since like April. But it'll change, and it'll probably change by state, the numbers, and the county. The county number is really big too. So right now we have open, you check in with a mask. You can visit in the room, 2 people with no mask. We don't ask if you're vaccinated or not. You know, it's not about that, but you will need to follow those things. Visiting, we don't really have visiting hours. You know, we do try to, you know, allow the person like have meal times and stuff by themselves. It's all individual. You know, maybe they eat better when you're with them. Maybe they do better when you're not with them at meal times. It's all really up in the air. We don't want people staying up. It is other people's homes, so we don't like people staying 10, 11, 12 o'clock at night or coming in at 5 or 6. Plus, this is now their new home and they're adjusting. So,
yeah, I would add too with the advocating is, you know, get to know the staff caring for your loved one. These are human beings working their tails off, or, you know, not a lot of money, not what they deserve for sure. And so partner with them, try not to make it adversarial. And if there are issues that need to come up, those can be addressed, but try not to make it adversarial. That's the whole, you get more flies with whatever, or punny, whatever, you know, I don't know, whatever, I'm tired. But the point is, these are folks who you want them to come to love your loved one as much as you do. And so, you know, make them your friends, make them your allies as best.
Ditto, and ditto. I can just say that. And most of the people here are very, very loving. I mean, they move me. I have had to work the floor a few times as a nurse, a real nurse, but I mean, they are so loving and they know your people so much. It's like, when? No, she don't like gravy. What? You know, no, give her meds like this, or they like it. You know, they know so much about them. It did me so good as a manager to work with them side by side, to see how much they know and how much they care, because they love, but they are, you know, they're nervous about family interactions, especially the frontline people, because they don't want to be, you know, they're trying their best. They really are. I am glad that they show up, especially in this COVID time, even pre-COVID, but you know, they love your people. You'll be in, and if you don't love our people, you're not going to be lasting long, because the staff will give you a whole heck of a lot of heat if you're not taking care of our people, you know, so, you know.
I think the other thing is just, if the facility your loved one is placed at is further away from home, or if your work schedule makes it harder for you to visit as much, that doesn't have to be the reason that you're not engaged and don't know the staff. I think it's always good to let the staff know, whether it's the manager or the frontline staff or the CNAs. I think especially the CNAs and the techs, that, you know, I'm here, I'm available, even if you don't see me in person. I want to be engaged and I want to be involved. Because I think that's, your absence, your physical presence, your physical absence doesn't have to mean that that a facility doesn't know that you're involved and doesn't know that you care. I think it's okay to, you know, call or make sure they have the best numbers and
set up phone times, FaceTime technology. I mean, if COVID would have happened, like pretend 10 years ago, it would have been a lot harder. I mean, it still is hard, please. But we've got, you know, electronic stuff now. We got FaceTime and stuff that people are able to connect with their loved ones. You know, we got this rolling thing. You know, just technology. You can stay connected with people. And then I would say, if you're talking with the staff or you have concerns, you know, find your contact person, whether it's a staff nurse, a social worker, you know, or the nurse manager. Did you guys get that?
Got it.
Okay. Anyway, or the nurse manager, and then talk about things when there's, you know, like issues. It might be, it's like, so let's deal with it before it gets into be something big, you know, if it's a real concern, or, you know, because we're a team, you know, if this works out, everybody is doing better by it, you know, so.
Yeah. There was a question about family councils. Do you have a family council at your facility, Gwen?
You know, we did. Again, sorry, it sounds like a broken record, but pre-COVID, yes, we did. A lot of times the family, because we have a long-term care floor upstairs, it's 32 bed long-term care. We got a 32 bed, you know, Huntington's unit, but right now it's just a we'll love you up unit. Mostly Huntington's though. And then we got the rehab unit. So it kind of comes and goes. And again, with the caregivers, I always tell the caregivers to try to get involved in some type of support group or something, because you can't do it alone, you know? But a lot of our families have just been so relieved to have their families placed and cared for, and they can get a hold of the staff, so they can bring up issues. So, and the Huntington's unit, the family councils have never, I don't know if they've ever been a part of it. And it's always a small group of people from the other units and stuff that would sometimes show up and sometimes not, you know.
Yeah, I have sort of remote experience with it from a long time ago. And I can say I've seen family councils that were very effective and some that were less and kind of undermining the care even. Kind of that group think can go good or bad. And so I think with the family council has the goal of advancing the care for everybody and not nitpicking, that's going to be far more effective for that council to spend their time on. So question about hospice in long-term care facilities. I can take that if you want. I have a lot of hospice background.
And then I gotta add though, too.
Yeah, do you want to start or do you want me to start?
No, you start.
Okay, so hospice is a level of care for people who are at the latter stage of their life, typically defined as 6 months, but of course nobody has a crystal ball. And that care can be provided wherever the person lives. Wherever their home is where hospice can be provided. So that can be at home, that can be a hospice specific facility, but often it is hospice staff within a long-term care facility. You know, the best way to look at it is in the most effective way, the long-term care facility and the hospice will work together and your loved one will get more care because there's just more people, as Gwen likes to say, loving on them. Most long-term care facilities have contracts with a few hospices. Others will say, well, we don't have a contract with that one hospice that you want to use, but we're willing to do a single time contract, but they have to have some legal contracts in place to allow for HIPAA business associate agreement type, you know, matters. But it's really a great way to bring in an entire group of people who are not replacing the care that they're getting at the long-term care facility, but enhancing it. Gwen, please add, or I can continue, but go.
God, you guys, this is my thing. I love hospice. I remember when they first came to us, it's like, we got this, we don't need any help. And then once I finally listened, it's extra help. And I'm not getting political. I'm just saying my tax dollars go to a lot of things because people will say, well, who's paying for this and stuff. It's like, I don't really care if it's hospice. You're getting extra care for your loved one. That's another set of eyes. It's an extra shower. It's somebody else coming in that's just for you that day. They can help with the challenges as things are progressing. They can help families heal or come together. It's way about comfort, keeping people comfortable, helping with whether that's morphine or things like that, helping. This is an end stage disease. We want people comfortable. We're not addicting anybody. We're just having them comfortable. Okay, I lost my train of thought. I just cannot say enough about hospice. I know that I'm a better person, a better nurse, a better advocate for my residents. And I just can't sell them enough. And I'll have staff come to me to say, we should see if so-and-so can go to hospice. It's like, no, because I want to fix everything. I just want to make everything all better. And it's like, they know. And hospice doesn't mean, most of us, we think of hospice that it's imminent, that, oh my gosh, it's going to happen. And it's like, no, our people stay on and recertify for hospice, for several times over. Some get kicked off because they do better and then come back on. So it's to me, it's all about comfort. We don't know when anything's going to happen, but it's all about comfort, for everybody entitled and stuff.
And hospice is paid for by Medicare and commercial insurances. So it's usually not something that's going to cost you as a family member 1 cent more. And so why not do it?
And they're strictly regulated too. So they've got a lot of guidelines and stuff, so, and there are different services, around. And if you are in a facility, it is about contracts. But don't worry about that. If your loved one needs something, you advocate for it, or you call one of us and we'll get on that bandwagon to help, you know. So not everybody's a fan of hospice, you know, providers and stuff are, why hospice? And I just say, why not? You know?
Yeah.
Okay, in the closing minutes, this has been a really fantastic conversation. Each of you certainly is an expert in this area. We have a few minutes left. I'd like to give each of you an opportunity to kind of give us the most important thing that you would want an HD family to know about. And whoever would like to start can go ahead.
I think we all
You
missed the
dropped
last
out at the end
two.
there. The
Yeah.
most important thing.
About long-term care. What should families know? From your experience, what is the one thing you want families to know about long-term care?
Plan early.
Plan early, yes. I think also just it's important to realize, while there are HD specialty facilities in some places in the country, there are a lot of states and areas where there are not facilities that have a specialty in HD, and that does not mean that there's not a good facility for your loved one. Even if, you know, you're looking at facilities and you can't find one that has, you know, HD experience, that's okay. What's really important is the quality of, you know, the staff there, the connections you can make, and their willingness to learn and, you know, be prepared to provide care for your loved one, to team up if you have a HD specialist, to work with them, to work with you, and take your expertise on board as well in dealing with this illness. But I think sometimes people, you know, they will reach out to us as social workers and say, okay, we're looking for a facility that specializes in HD. And we have to say, you know, unfortunately, we don't have any in the area, but, you know, we can give you some leads, but also just to know that that's not the end all be all criteria for a good placement.
Really good advice. I always tell people I can teach them about HD. I
Yes.
can't teach them to be good caregivers.
Yes.
So if you find a place that's got good caregivers, I'll teach them what they need to know about HD.
I think I echo everything that Stacey and Erica have said. Also, it doesn't have to be, again, I think sometimes we think of it as a bad thing that we're sending somebody. I think it can be really positive, and it really gives family that chance to be the family member again and not just the caregiver. And I think that's a really important thing to remember. Also, when I do in-services, we sort of said it before, the CNAs, the techs, they are, to me, such an important piece of it. I think we tend to want to go up to the nurses and the nurse managers, and it's good to get to know them. But I find the CNAs work so hard, and they are there because they genuinely want to be there doing that job, and they will love your relative and take care of them. In that it'll never be the same as you, but like they genuinely want to do the right thing. And so get to know them and help them know your family member.
Okay, I can't just say one thing, but like ditto. But like I say, the caregivers, people are not usually in this business for, you know, making money other than what maybe the media might say. I mean, people are really, it's a hard job and it's very rewarding, you know. And if I can make somebody happy for that moment, or, you know, the staff are happy too, you know, so, and the residents happy, you know, so give us a chance, you know. It doesn't, again, I agree, it does not have to be an HD facility and stuff. Yes, they would know some, but you got some social workers around that'll, you know, help them out and stuff. You know, you just need good caregivers and stuff, but there will be some challenges trying to find that, but just start early. You're right now on a place, adding us in your little tool belt and stuff, you know, you're gathering information, you're doing good.
Well, thank you all. I do want to remind folks that HDSA does have several publications about long-term care that you can access on the HDSA website. One is the Family Guide to Long-Term Care, which is kind of an overview of a lot of the information that was discussed today in terms of payment and how to choose a facility and questions to ask and what to look for when you tour a facility. We have the Family Guide to Long-Term Care, which kind of helps families who are taking care of their loved one at home to be effective as a caregiver through the different progressions And then we do have a handbook for long-term care facilities. And all of these are available on the HDSA website for downloading, or you can order a copy. And as Erica mentioned, we do have a number of social workers. I think we have more than 60 social workers in the HDSA network through our centers of excellence and our chapters, who are all available to help you through your journey in long-term care and in Huntington's disease. So you can find the closest social worker in the HDSA website by going to locate resources, and all of them are there to assist you in your journey now and in the future. I'd like to thank our panelists for taking the time to talk about long-term care today, and thank you all for attending. Be sure to join us in October when we talk about psychiatric symptoms with Dr. Rapp and Dr. Tripp. Till then, take care and thanks again. Have a good day.
Thank you. Good luck, everybody. Be
Bye-bye.
kind.
Bye.